Thank you. It's such a great pleasure to host this conversation today with Dr. Ali Khan. He is a member of the APF President Circle. I have to say that first, otherwise I'll forget, because there's a long list of accomplishments here, and I won't do the bio justice, but he is currently the Dean of the College of Public Health at the University of Nebraska Medical Center, and he is a former Assistant Surgeon General with the U.S. Public Health Service. He has multiple degrees to his name, medical degree, master's in public health, and also did his pediatrics and internal medicine work at the University of Michigan. So go Midwest. And so today we're going to be talking with Dr. Ali Khan about his book, The Next Pandemic, on the front lines against humankind's gravest dangers. And what I think is super interesting is that this book was published first in 2016, and I think there was an update in 2020. So all the more reason for us to talk about this now, given the current state of affairs. And so this book, so first of all, kudos. It's an amazing read, but you've also made it very relatable for the layperson, and it's quite enjoyable, and there's some fun little anecdotes and some wonderful vignettes in here. So I encourage everyone, even if this is not your specialty, to take a look. So in this, you detail your 23-year career as senior director at the CDC, and how you led and responded to a variety of domestic and international public health cases. And I sort of, as I was reading it, like, it took me back in time, and I was pinpointing kind of where I was in my life when these various crises happened. So it just shows you like how much these kind of outbreaks and these diseases become just part of the background of our daily lives, right? And so it's required reading for that as well. So first, I thought we could start off by just you telling us, tell us about the book and what motivated you to write it.
Well, thank you very much. And that was a very, very generous introduction. So we should have said "Go Blue" when we talked about my 4 years in Ann Arbor. Yes. So what motivated me to write this, you actually hit it on the nail, right? Which is that I didn't want this to be a technical book about epidemic preparedness. I wanted this to be very relatable in terms of stories of somebody who is essentially a disease detective. And so these are essentially, each chapter is a disease detective story of finding out something's going on and figuring out exactly what's happening and what are the right prevention measures to put in place to shut down an outbreak. And so I wrote it to try to give people a better sense of who are these public health people they hear about all the time, and what are they exactly doing. And so I hope that's what I conveyed in a first-person narrative, to get people sort of drawn into public health and how relatable it is and how much it truly is about solving problems.
Yeah, no, I thought that came across right away. And, I come from a career in public service as well. And, you're doing God's work, but you're also, our taxpayer dollars pay, all those salaries. And it's good citizenship on our part also to know kind of how the experiences and the contributions of this community unfold. And I thought it was interesting that you used the word disease detective. And that's not something I was familiar with before I read this. And you talk through in the book kind of the various mechanics of from when you get sent out to a place, and then how you put together the clues and your queries as to how you figure out what the disease is. So can you walk us through that a little bit? Like, what's the process for a disease detective if you're, you've been dispatched to the other end of the world? What do you start with?
So actually the first part starts with the before the dispatch part, because at CDC, the Centers for Disease Control and Prevention, where I worked for 23 years, and I joined in their disease detective training program, which is called the Epidemic Intelligence Service Program. So the first part is actually making sense out of what you get. Is this a real outbreak or is it not an outbreak, right? So often we get called about a potential outbreak and it doesn't turn out, you ask some early questions. Is this the first time you've seen it? Have you seen these in the past? What is it due to or likely due to? And so you have to sort of take care of that first, right? Then you think about the team you need to put together to understand what the outbreak may be before you then sort of parachute in or go into a country. And really, I like to talk about how this is about supporting these countries. And I hope we'll come back to that message again and again. I'm not a big fan of parachute epidemiology, and my greatest passion is about how do we get outbreaks solved in countries by themselves, right? With good sharing of data so that we can all learn globally. But for a big chunk of my career, these were very exotic diseases that you wouldn't necessarily have national expertise on, and you needed to invite others from outside the country with epidemiologic expertise, zoonotic expertise, laboratory expertise, infection control expertise, which is how these units get put together. So it starts with understanding, really, it's the where, when, how, why questions you ask right away. So we talk about it in terms of, the people, place, and time. Who got infected? When did they get infected? Where did they get infected? And you put that together to try to give you a sense of who are the real people who are infected with this new condition. So surprisingly or not surprisingly, when you go to an outbreak, it's like when you're a medical student, or even when you're on Google, you're reading about a disease and you think you have it. Well, the same thing happens during pandemics or an epidemic. You go to an outbreak and everybody thinks they have it. And that's just not going to do, right? So you really got to narrow it down to the ones who really have it, right? And then the ones who really have it, as you put together this, sense of, a person, place, time, then you go, okay, these are the ones who have it. This is when they got it. This is where they were. And then you try to figure out what is the disease. So most of the diseases I've investigated, they've usually been brand new, never before seen or not seen in decades, right? So there's not a lot of experience. And then you take those individuals, you do the laboratory testing, and you sort of figure out what is the disease. Is this the new SARS virus, right? Mm-hmm. Is this the new Ebola virus? Mm-hmm. And then you use your knowledge of who got infected and how you're asking then the questions of those who really were infected. How did they get infected? Do we think they got infected because they touched somebody? Did they get infected because somebody coughed on them, or they touched some bedding or something? Or did they get, maybe somebody injected them with a needle that wasn't clean? Or maybe, it was these small particle aerosols. So they were, in the other room and they got infected. And so you use that information to do what you're really passionate about, right? So as a public health official, I didn't go into public health to be a bean counter, right? It wasn't to say you have 42 cases. What I want to talk about is how many you prevented. So you find who's infected, how they got infected, what you think they're infected with, and then that transitions into the good part, which is the disease control part, right? That transitions into, okay, you got infected because of, let's say, contaminated needles. Okay, let's think about who's using these in the community. How do we stop their use, right? And there's a great case, for example, in Pakistan, as you know, with this tragic HIV outbreak that was likely due to contaminated needles being used between people. Or it's due to infection in a healthcare setting. So what are we doing in the healthcare setting to protect you, right? So you use all of this information to then put your prevention strategies in place, and then you come back and you look at them and make sure the prevention strategies are working. So that's what a disease detective does, right? And like any detective, you have to figure out what the right clues are as you put that all together.
Yeah, well, what I thought was interesting is, in a few of the different vignettes where you're talking about certain diseases, there was what was happening in the present in the collection of data and interviewing people. But then, you mentioned HIV/AIDS. There was a part of the book where you say that this was around, the virus was around for a while, and it wasn't until something like 60 years later that all of the dots started getting connected. And I found that to be really fascinating, because it's just like any other body of research, it builds upon each other. But at the same time, you need to understand that, like, it's first, like, what you're looking at might not be new, right? So and that makes it even harder, I think, to detect something. So talk a little bit about that. Like, that requires a different kind of critical thinking. It's not just like technical book knowledge, right?
No, so public health is as much science as it is art. To say, what do we already know and how does that link to what are we learning now to try to understand what's going on? So HIV is a great example, but we have numerous examples of where you get a threshold of enough cases, and we are firm believers in that astute clinician that says, something's not right, that would trigger us to come and do an investigation. Let me give you another example right here in the United States, hantavirus pulmonary disease, right? In the early 1990s, we had this outbreak that started in the Native American reservation in the Four Corners area of people who all of a sudden were dying. And this triggered something because these were often young people, right, who were getting this sort of fever-based illness and dying. And in the end, we realized that this was actually due to exposure to deer mice. So these deer mice are infected with these hantaviruses, and then they infect people through various ways, often as you're sweeping or being inside of these buildings that are infested with these deer mice, you can get infected. And that specific year, we saw this outbreak because of climatic conditions that led to a lot of these deer mice, so that they were more likely to infect people. But then you go, wait, these deer mice have been around for a long time, and the virus has been around for a long time. So cases, you go back and you think cases have probably been occurring for hundreds of years that were never recognized. And then what happens is an astute clinician. So what happened to us was we had a clinician who contacted us and said, about 20 years ago, I saw a case that looked like this to me. But we didn't have a name for it. But he had saved the pathology blocks. And we went back to the pathology blocks, and he was absolutely right, that this case in Idaho was really hantavirus pulmonary syndrome. So the physician had recognized something was wrong, but we didn't have the vocabulary and the tools to know what was going on. And we had to wait for this cluster of cases to build the vocabulary and tools to say, oh, hantavirus pulmonary syndrome.
Fascinating. So I want to read a little excerpt from the book before I ask the question. So let's see. Where is it? I have so many notes here. I really nerded out on this, by the way. I have lots and lots of notes. All right, I'm just going to go to page, I believe it's page 25. Okay. So in this chapter, this is just the beginning chapter called First Blush. Let me just set it up so people know what we're talking about. Okay, we're talking about swine flu here, right? Yes, okay. So you went on to talk about swine flu and the outbreak, and then this is where it starts. The strain is still out there, by the way. In 2014, there were more than 30,000 cases in India, with more than 2,000 deaths. There were also deaths in California and Texas and in Canada. It is possible that this strain of swine flu did indeed originate in Asia. We don't know. Either way, it drove home the point that no country can afford to isolate its public health system. It has to be part of a global public health infrastructure. You can't get away with saying, we're the richest country in the world, we have good doctors and a solid healthcare surveillance system, we're safe. It just doesn't work that way. So obviously this spoke to me in volumes, given how we've endured the COVID pandemic. And this passage is related to a lot of things. One thing it's related to is just the kind of the relationships between states and then the multilateral organizations and everyone involved, the entire community of global public health, and how they interact or maybe don't interact. But it also has to do with this, this sense of like, we're better than one place or another. And so we go in to save. And I think that narrative sort of works in your head, but in practice, it's something very different. And so I want to talk a little bit about that in practice, like when you go into a country and you should work with people on the ground, and there's a lot of diplomacy involved there. So talk about the importance of the local communities and what role they play in kind of response.
So can I start by talking about the narrative first?
Yes, let's do that. That's important.
And then bring me back, because I ramble. Bring
Yeah.
me back to the local community. So let's talk about this narrative and how this outbreak has proven to be, the king's new clothes, right? It's really shown how this narrative is off. So the US has had a devastating response, a failed response to the COVID pandemic, with a tragedy that has unfolded with, as you know, over 500,000 deaths, approaching 600,000 deaths potentially by the end of this year. And so richest country in the world, great public health system. In contrast, let's look at China, Australia, New Zealand, South Korea, Thailand, all of these countries in various ways handle this pandemic better, and they have essentially 0 to no cases. Mm-hmm. Now, it isn't without some economic turmoil that you would do that, because it means you need to have pretty strict border controls in a world that works on globalization and free movement of goods and services and people, right? But they have been able to they were able to get to 0 to no cases. The US was not, as were many European countries. Were not able to do so. So I hope that this is a wake-up call for all of these countries to say, okay, what are the key things we need to have in place to ensure that for the next pandemic, we are better prepared than we were for this one. Some of it is around technical competencies and strengthening our public health system, but a lot of it is around political issues and governance. And given your public service experience, here is Ali Khan, a public health doctor, telling you that politicians are more important to epidemics than epidemiologists and people like me, to be very honest with you, because those policy decisions, especially when they are divorced from good public health science, lead to what we saw happening in the United States. And this hubris has proved problematic for us. Hopefully with some more humility, when we now teach other parts of the world public health again, when they forget the fact that we didn't do so well ourselves. But, we need a different approach to public health globally. There's no doubt, given how interconnected we are globally, that we're only as strong as the weakest link, right? So none of us can step back and say, yeah, India's got 400,000 deaths a day, but it's India, it's out there somewhere, right? We'll just close our borders. Think of what that would mean globally if everybody said we're going to close our borders to India, right? What major, right? Major economy, travel, tour. We can't do that anymore, right? So we have to be global citizens. But it also means that, and hopefully the pandemic help prove this, because we couldn't go flying all over the world for the last year, right? That we need to build expertise within countries, with countries, for countries, and we need to get out of this, it's some version of the white savior complex, Shamila, and you can use whatever term you want, right? But how do we help when we show up to have that humility to say, it's your country, you're the ones most vested in the health of your citizens, and how can we bring what we bring? So we bring, humility and being humble aside, we bring strong technical expertise, strong laboratory, we bring that strong expertise. How do we help and share our expertise with you so you can do what needs to get done? And in the end, what you really want is you want to be a true partner with them, right? Not just a source of data or dollars, but a true partner. And I think that's where we need to go in global public health, is this true partnership with these countries. I'll give you an example. So I'll give you an Ebola example. So for too many years, when you had an Ebola outbreak, a parachute team would show up, including labs, to help you figure out what's going on. Well, because of the pandemic, the Democratic Republic of Congo showed us how they could do it themselves with their last two outbreaks. For the most, not that they didn't get external help, but not to the same nature. And we're very pleased that because of our relationship with the University of Kinshasa, they were able to do their own sequencing of the virus and say, yes, this is new or this is not new. And that's, I think, where we want to go, right? That they didn't need to send samples to the US or to Belgium or anywhere else, France, to get a diagnosis. The diagnosis could be made in country, and then they could then use that data for what they're going to do. And right now, I'll give you another India example. We are hosting a fellow from India-occupied Kashmir to work on from the Ag College, and she's very committed to her country and making sure that they have good diagnostics. So when she goes back, we are going to give her the tools, the machines, the equipment, and the reagents to help set up some of these systems there in Kashmir. And then over time, we want her to be a true partner with us. So I think that's what, when your question started with, Dr. Khan, what do you see about working with countries and local communities? That's what I see about working with countries and local communities, that it's informed and driven by them as opposed to some external agenda.
Yeah, and I think it has to be that way, but it also needs to be reinforced by these very important political narratives, as you mentioned, right? Political and leadership is key here. And I've noticed that not just in the United States, but in a lot of countries, there's been this contraction of a sense of global citizenship. A lot of countries are looking inwards, right? And so there's a global trend happening. At the same time, there's a global pandemic, which is forcing us to look at how we're connected to each other. And then the leadership was, in a variety of places, was not in the right place to kind of enable more collaboration. One thing I've observed and I'm worried about is that for the US, to engage other countries in kind of urgent matters, it's always easier to do that when you've had an established relationship, right, over the long run. And so there's this tension between kind of responding to the immediate versus looking at the long term. And I know that plays out in parallel, just within the specific area of responding to disease. And I'm sure all of you would love all the time in the world to research and think about the long-term implications. So how does that get balanced out? And I suspect that your students also ask you this question, right? Because you want to be helpful, but you also want to be really thoughtful and intelligent about what you do.
So to be honest with you, it's very hard to do the short-term work unless you're leveraging long-term relationships, right? And the U.S. tries very hard and does, I think, where I can speak best from is Department of Health and Human Services, the CDC work, to have those strong bilateral relationships so that when a problem occurs, they can call you for assistance. And it's more than just assistance, but then it's that scientific discovery and that advancement of science, which is about a global commitment, right? Because you're advancing science globally. So as opposed to becoming more nationalist, I think we need to become more globalist. And hopefully the pandemic showed us that, right? Yeah. That if the better sharing that there had originally been from China, likely that would have modified this pandemic if even those 2 weeks of difference, we had known about it earlier. And if we had all put in better measures into place, we're seeing it play out now in terms of how are we sharing vaccines and resources globally so that everybody can be prepared. Because to be honest with you, global travel is going to be very difficult until we do have a more vaccinated group of people worldwide, right? Otherwise, the virus can simmer somewhere, mutate, become a new variant, and the next thing you know, it's on your shores, right? You can't just sort of say that's an offshore issue. So yes, we need that political leadership to buy into why it's so important to engage globally and put in these long-term relationships that then allow you to be have a place at the table when something big happens and they go, yeah, these folks, they've been with us all this time, we're going to invite them to help.
But so what are the primary platforms right now to share information about COVID and the vaccination process and the next steps. I mean, I suspect that at World Health Organization, United Nations, like it's all happening there. But in terms of just more at the technical level, how are experts organizing themselves?
Oh, okay. Yeah, glad to help. So correct. So WHO has sort of taken the global leadership for the response and sharing information. And there's technical groups in all the areas, clinical care, prevention, that share this information. I sit on something called the Global Outbreak Alert Response Network of WHO. So this is a network of networks that provides technical support to WHO to help them sort of put out these guidelines globally. So that's what's happening at the national level. Then that cascades down to what happens at the subnational level, either, for example, like the European CDC, that's very good at doing risk assessments and putting out prevention guidelines, to the national levels, our CDC, and then obviously at the state and local, what information is shared that way. So there's really good mechanisms for data sharing. We just need to make sure that but those mechanisms are only as good as the quality of data that you get, right? And so we need to make sure that countries have better mechanisms to understand what's going on in that community, how many cases there are, who's dying, why they're dying, how many are dying. And that requires sort of that country level capacity. So yes, WHO can help sort of do the synthesis, but the synthesis is only good as the data. And for example, in India right now, reports of 300,000 to 400,000 cases every day. But some people are thinking that represents maybe, a tenth of the true number of cases, because there's just not enough testing in country and capacity to make that diagnosis. And the same thing with the reported number of deaths are dramatically underreported. And without good public health data, which I think I try to go back to multiple times in this book, you need good public health data to make good public health decisions to save lives. And without that good data, you're not going to save lives.
So in the case of India, was the lack of good data like what prevented us from kind of foreseeing what's happening right now? Because a lot of people were just saying, oh, it's, everyone had their own explanation for why India, and also Pakistan too, to a certain extent, like now everyone thinks Pakistan's next. So can you talk about what you think about that?
And Africa. Large parts of Africa. A little bit of this is a little too much hubris, right? This is a little too much of thinking you know what's going on when you don't. So in many of these countries, I think we need to be honest that they likely were somewhat protected because they have different demographic structures and social systems than the United States, right? So if you look at deaths in the United States, very heavily concentrated in long-term care facilities, right? And in other parts of Europe, there are not this same social structure for long-term care facilities in India and Pakistan and large parts of Africa. They also don't have the demographic pyramid with this large number of people who are 65, 75 years, 85 years old and older, right? So they have a different pyramid, different social structure. And so that may have protected them to some extent. And people assumed that that was enough, that they were never going to get outbreaks. Well, we know, and there's good data, for example, from Zambia, that the number of true cases, if you go to a hospital and actually test everybody, is dramatically higher than what the country's claiming. And India is a good example, and India is the best example, where India essentially declared victory over their pandemic in January or so, right? And then they didn't have good data to understand what was going on with the variants so where they were having cases, where the variants were. And then on top of that, they decided to drop their public health measures. So they were having rallies of tens of thousands of people, and they continued to allow the Kumbh, which is essentially has become the largest super spreader event in the history of mankind, right? And this is a lovely religious festival. So, a big fan of religion, needless to say. Part of my personal life is to chair the Tri-Faith initiative here in Omaha, which is a Christian, Jewish, and Muslim community that's purpose-built Muslim community that's come together to celebrate the difference in religion. So all for religious festivals, but maybe during a pandemic, you rethink your religious festival, right? And the social distancing. And so the combination of not good data and then doing things that are contrary to good public health advice leads to 400,000 cases a day in these tragic stories we're seeing coming out of India.
So sad. Well, you talk about this in the book in a couple of the African countries that you had to go to, and how cultural practice and tradition kind of prevented you all from managing the situation, even with dealing with the bodies of the dead, for example, and the, what we like to call magical thinking. And I think we've had our own magical thinking here in the United States as well. So,
well, yes, we've the magical thinking that this was going to go away by magic. It was going to be done by the summer by magic. Yes, we had our own magical thinking in the United States about this pandemic. And in many cases, how we approach this disease was not that different what I've seen in many countries in Africa when I've gone to investigate these diseases. The same magical thinking about this disease, and we blamed it on instead of blaming it on our own public health, we decided, unfortunately, to use really racist terms of China virus or Wuhan virus or Hung flu, right? Which doesn't help the situation, and actually stokes anti-Asian racism and hate crimes in the United States. But this is unplayed multiple times, and I've seen this unplay in Africa multiple times. You started the question with about religion. So, we've had super spreading events. This is where an individual causes many more than the usual 2 to 3 cases, often 15, 20, 30 or more cases. And we've had super spreading events. I know one where we investigated where this very holy man had died, and they had washed his body, and then the washings, those liquid, the water from those washings was used many people used it to wash their hands so that they could get the blessings of this prominent holy man, And so how do you tell people, how they can meet their religious obligations but not put people at risk? And so that takes a while to do, and you really again need to work with the community, the religious leaders in the communities, to do that. The same thing, so that was true on the Muslim side of the house, but it's also true, if I think about it, on the evangelical side of the house, where there's a lot of laying on of hands. So if somebody gets sick, everybody touches them to help them feel better. Well, the last thing you want to do with somebody with Ebola is touch them. Can you lay on of hands without the laying on of hands part? Right. And so we had these outbreaks of people who, even though they were hospitalized with Ebola, they would go back to their church to go seek spiritual relief, which is, I can understand that. They want the spiritual relief, but part of the spiritual relief came with a lot of the practitioners and parishioners touching them. Right. And then all of a sudden that's led to another outbreak. So you really need to think about the social context and work with the community to get them better. I want to extend this a little bit more, because I have said that I would trade 3 epidemiologists for 1 good social anthropologist during a pandemic. And I think the same thing would have been true here in the United States. Is how could we have traded a couple of brilliant epidemiologists for more social anthropologists to help us understand how the outbreak was unfolding in the US, and how to help people understand that these public health measures what was going to protect them, and they were not what was limiting them, right? And that was the conversation that unfolded in the US, right? It was my freedoms versus saving lives, and that was just the wrong dichotomy that we set up.
Yeah, no, that was not helpful. And I also think matters of health and medical history talking about them varies from community to community. And they're often just not spoken of because, you want to protect your family. And so there's not a practice of talking freely about these issues and brainstorming. But I observed happily that a lot of different religious communities were like being very innovative and, you know, taking mass to virtual mass and explaining why it's important. And, you know, so, and wearing a mask is kind of part of your, like, you know, religious duty to take care of your fellow, you know, humans. And so that I thought was like very promising, but I hope it stays, right? It has to evolve. So
I am with you about hoping it stays, because the way our current structures are set up in person is not kind to people who have mobility and other issues sometimes.
Mm-hmm.
And wouldn't it be great if you can go to mass without having to drive in a half an hour or whatever, find a parking space, etc. But if you can get that spiritual part without the associated logistics of getting it. And I think during the pandemic, many congregations were able to expand outside of their traditional base because they were willing to go out and make themselves open. And so that I would like to see a lot more of. You know, I truly believe in that integration of in public health, regular, you know, healthcare, and spiritual health. How does that come together for a better person?
Yeah, no, I'm really interested in that too. And just to follow up, but before I do, I wanted to tell the participants, please do submit your questions. We have a little bit of time to ask them, and I'll go to them after this. So to your point of, you know, having a kind of a cross-disciplinary approach to public health and having other people, you know, having an anthropologist there with the medical folks is good. How are students of public health looking at the world right now? And are they scared? Are they excited? Are they questioning their career choices? And I ask because in your book, you talk about fear. I think, I can't remember which country you were in, but you were on a plane and the person next to you was praying because, you know, thought he was going to die. And, you know, you said, if you've lived a good life and you have no regrets, you'll be fine. Right. And you yourself say that in the book that, you know, if you're fearful, you can't do this work. And so, I mean, I look at what's happening now, it's very scary. And so what is going on in the mind of our future public health experts?
So I tell my students there's no better time to be in public health than today. At least you don't need to tell people what public health is, which is a start, right? Right? They know who you are and they know what you do. But there's no doubt that it's a challenging time. We are already seeing numerous people who have quit their jobs because they were threatened during this pandemic, right? And many more that have just hung in long enough and probably will leave now as vaccination increases in the United States. So we are going to have to build not just trust with the politicians, but we need to build trust with the communities, so that the first time they see a public health official is not somebody who's telling them, no, you can't go to a bar because of a pandemic, but they're used to seeing public health officials from the day kids are born with baby boxes and car seats and to soft bedding and folate in pregnant women's vitamins, to all the way throughout their lives where they're like, oh, these are the public health folks. We know who these folks are. They're out there working every day to protect our health. And now when they show up and say, don't go to bars, restaurants, and gyms, we trust these people. We are not going to go to bars, restaurants, and gyms and get this disease under control. Yeah. So I think this is the big challenge for public health people. Now that the community knows who we are, to really build that trust with the community so that the next time this happens, and smaller outbreaks happens all the time, the community will really sort of know who we are, trust us, and do what or at least work with us to do what we suggest. So this is the big challenge. But it's not just in infectious diseases, right? So yes, you know, infectious diseases will always be a threat, but let's not forget the continued challenges in the United States around heart disease and cancer, right? And how are we going to address that for our communities? So the U.S. spends twice as much per capita on healthcare healthcare than any other nation in the world, which is just mind-boggling, right? That almost 20% of every dollar we spent is spent on healthcare. And I would say that would be a good investment if we got the best health in the world. And we actually, if you look at indicators like life expectancy of all of the other high-income countries, ours is the lowest, right? If you look at people with 2 or more chronic conditions, so for all the measures of health, we do worse while spending twice as much. So this is the other things that public health officials need to do, is help people remind our communities that health is more than health care that everybody's willing to fund. It's the social determinants of health. It's whether they have a job, right? Their education, the safe neighborhood, the environment that they're in, the food that they get. It's very easy for me to say, eat healthy and take a walk, but in your immediate, and I've said that as a physician in the past, and now I think about what a mistake I was making without asking the right questions, right? So it's easy for me to say, 6 fruits and vegetables every day, but is the most convenient thing to you a convenience store with Twinkies, right? It's easy for me to say, go take a walk. If I say, you can't, so, at least I'm conscious enough to say everybody can't have a gym membership. Fine. Go take a walk in your neighborhood. Are there street lights in your neighborhood? Are there sidewalks in your neighborhood? Are there cross cuts in your neighborhood? Curb cuts for people who have mobility issues, right? Is it safe to walk in your neighborhood, right? So all of those social determinants of health are really important. So again, fabulous time to be in public health.
Yeah, no, it was very clear to me as the pandemic unfolded, like how much of it opened up my eyes to all of the inequities in our society. And I consider myself pretty like aware person, but it became very practical. And for example, like I live in a neighborhood in Northwest DC. The main street dividing my neighborhood and another neighborhood is 16th Street. And that's the street that goes down to the White House. So on our side, we didn't have many COVID cases. Right across the street, which is a much poorer neighborhood, less expensive homes, highest number in all of the district, right? And so we had to kind of like, we thought through this and we talked about it in our family, and you had to like come to terms with a lot of these things, right? And a lot of those families from the COVID affected neighborhood would be working in our houses, right? And so there was just, you were connected in ways that you knew, but they just became much more vital to understand. So, and I hope that's something that doesn't go away. I hope we continue to kind of understand those differences.
So the virus exploits human vulnerabilities. So if you're obese, if you have high blood pressure, if you're old, if you're a male, these are certain risk factors that put you at higher risk of getting severe illness and dying. But the virus also exploits our social vulnerabilities, right? And you just gave a great example of it. For people who don't have, I have the luxury of sitting in front of Zoom right now and talking to you. There are all sorts of people that they don't have that luxury. They have to get on a bus, public transportation, go show up at their place of work, stock some shelves, interact with hundreds of people during the course of the day, and then come home. Well, that puts them at higher risk of getting infected, right? So this virus really extenuated those social inequities. And when you layer that on top of what's been going on in the US in the last year in terms of police violence and irresponsible policing, I hopefully, one more way for us as Americans to think about health equity issues and equity issues in general, on how do we address structural racism in America for better solutions for all of us, including better health solutions.
Yeah, absolutely. So we have a question from Faraz Babar, who's asking, I'm very happy with the kind of support the government provided to tenants, employees, as well as employers. Do we have some ideas on how to extend this sort of support to people in India or Pakistan or Africa, where the choice, is, come the next pandemic is to starve to death or die of the pandemic? I've gotten several questions too from our APF members on how to help people in India in particular, and what we can do. So
that's absolutely a great question. I think most of the support, so obviously national and international NGOs and charities that can help provide direct financial support. But that's not going to solve the problem in India and Africa and Pakistan, right? The solutions have to come from within the government to think about how do they provide direct support to people who are affected, and how do they put in smart public health measures that allow as much economic activity as possible, while shutting down those activities that lead to the most risk for individuals. So under no circumstances, can you think about why should we have mass political rallies, right? That makes no logical sense. So until vaccine becomes available, you need to layer some modicum of public health measures. And then, there's a great effort now to increase vaccination efforts that will also help out in the future. But I want to take this conversation back to the beginning conversation about building national capacity, and that building national capacity has to be in their public health systems, and so that they can understand what's going on and provide better advice to their citizens, but also, potentially building their own networks around medical devices and therapeutics and vaccines. India is one of the largest vaccine producers in the world, right? The All Serum Institute. So what probably should have been happening, and it's easy to say in hindsight, is while we were busy giving money to Pfizer and Moderna and J&J and AstraZeneca to make enough vaccine for us, the global community should have been thinking about how do we multiply the All Serum Institute of India by 4 or 5 so that there would be enough for everybody, which is what's happening now, right? The US has made significant commitments. They're going to scale up a brand new facility in India to make J&J vaccine. So there's a massive scale up going on now, but it would have been nice to have thought through some of those issues of massive scale up, 6 to 9 months ago.
Yeah, absolutely. So just on the subject of the COVID pandemic, Anwar Marchant is asking, what can we do differently going forward to prevent the tragedy we're witnessing today?
So multiple things going forward. So at multiple levels. So at the global level, I think we need to start with what do our global public health systems look like, and advice for countries for their global levels. But what does global health information sharing look like? So how do you find out about outbreaks sooner and do the right thing sooner? WHO was very slow in declaring a public health emergency of international concern, as everybody knows, right? And the first time they didn't even do it, right? They had to go back to a second meeting to do this, despite the fact that we already knew the disease is broken out of China and was in Thailand already. So that we can do better. Then of the information sharing at the global level and global guidance at the individual national levels, we need to build our public health systems, and those systems need to be better integrated with public health, with healthcare. What happened, which I would never have predicted but should have predicted, is the outbreak became a big issue in the US the moment the healthcare system was overwhelmed. Right. And so in the US, as in many countries, we're more willing to pay for treatment than we are to pay for prevention. So despite the fact that we gave hundreds of millions of dollars to hospitals, when the pandemic started, nobody said, you know what, we are going to set up an isolation fund. So if you get isolated, you're going to get hundreds of millions of dollars to stay home. If you're going to get quarantined, we're going to give you hundreds of millions of dollars to stay home for 14 days. That was not the approach we took. Right. And if we have taken that approach, people who are infected or potentially infected would have stayed home. Yeah. Right. And the outbreak would have just shut down. But that's not the approach of where we decided to put the investment. So we need to rethink those investments in the future.
Which countries did do that? Was it South Korea and
South Korea and was a good example, but New Zealand, Australia, they all had strict isolation and quarantine processes, which is why they have 0 cases right now. China has 0 cases, and they gave significant financial support to make sure people. They also are have a different government structure that leads to a
easier.
lot more compliance than you have in the U.S., shall we say? But they also got to 0 cases. But we could have done it voluntarily by just making sure we paid people. The other thing is paid sick leave, right? If you're sick, but you can't afford to take off because somebody's got to make sure the mortgage or the rent comes at the end of the month, you're going to try to go to work, right? So all sorts of policy choices that we could have made early in the pandemic, which would have led to a very different pandemic.
Yeah, agreed. Well, on related to that note, Dr. Humayun Chaudhry, hi, Dr. Chaudhry, he's a frequent attendee and friend of APF, is asking, when we go from containment to mitigation, are smart lockdowns better than full city lockdowns? Or does it really depend upon the virus you're dealing with? Pakistan is trying to use smart lockdowns.
So, Dr. Chaudhry, so it does depend on the virus, but it also depends on the local situation in terms of how is the disease spreading locally, and then doing that. So for example, maybe all you need to do in terms of a lockdown is in-person dining and gyms and bars, although there's probably not a whole lot of bars in Pakistan, I believe. But anyway, the point being, if you have the good epidemiology that says this is where the disease is occurring, then that's where you would potentially, if you need to lock down, you would lock down. Ideally, you don't need a lockdown because you have good public health measures to identify your individuals who are sick, isolate them, quarantine their contacts, and then move on. And then your money then is being spent on convincing people who need to be isolated, and convincing and financing people who need to be quarantined. And I would call that, Dr. Chaudhry, smart targeted public health. Right. So instead of going for everybody locked down or smart lockdowns, where your case is, use your resources to get isolation and quarantine and contact tracing in place, and and align your financial incentives around making that happen.
Yeah. Well, I just, this is just anecdotal, but in my experience with like a full-on lockdown, I just found that it actually increased the tension between kind of people in the state or their local governments, and regardless of your political persuasion. I mean, it was, just not popular, and it also like fomented some of the distrust that was already out there. So, I think you're right. We just have to think about it in a longer term context as well. Smart public health. I like that. The next question is from Faraz Babar, who's saying, keeping the focus on the next pandemic, I understand WHO has its hands somewhat tied when it came to investigation into the origins of COVID in Wuhan, but we have to do better next time. Is there a plan or protocol WHO is setting up for next time?
So unfortunately, this isn't something that WHO can do. And I'm not even sure if they're the right people to do it, but that may be a different conversation around governance and political people. But the honest truth is that we don't have a global mechanism that compels countries to share information, right? And until we figure out the right set of incentives and disincentives to have data sharing, we're not going to get there. And the IHR, the International Health Regulations, has proven inadequate to the task. And this pandemic is a good example of this. So we need to think of different mechanisms that would have countries share their information rapidly. For example, in China's never shared samples, I think, to date from the original cases, right? And yes, they've shared genetic sequences, but it's a little different than sharing the samples, because then all of a sudden you can look at other things in the virus besides the sequence, which are also important. So I think, to be honest with you, who was this, Mr. Faraz?
Faraz, yeah, Babar.
Mr. Faraz, I think we need to think about, and maybe this is a better question, to be honest with you, for our host, is what are better global governance mechanisms that compel compliance in these matters, right? Like even like if I think, and Shamila helped me, like with the WTO, there's actual penalties, right? You can get fined and stuff like that. It's not, whatever that means, but there are no such penalties in the IHR.
Right. And also China is, this isn't the only issue that it's hard to get China to share information on at the global community level. And so it's, I think it's yet another example that shows the multilateral institutions that we do have in place are for a different kind of world, right? These are all post-World War II institutions, which were responding to different kinds of threats and different kinds of communications platforms and technologies. And so I think it just really begs the question of like, how can we create just a new kind of infrastructure for our new challenges and the way that we communicate? And that, I mean, I don't want to be a pessimist on this because I think anything is possible, but it's really hard for governments to work with each other because bureaucracies by design are supposed to be kind of overly cautious, risk averse, and thinking about every contingency possible. So what I've observed as being more effective is when the private sector has a certain interest or concern and they push governments for either kind of more involvement or more collaboration, and they're backed up by a good kind of engagement with civil society activists, et cetera. So we're at this point where this has affected everybody. So it's not impossible that you could form a coalition of this kind, but the question then is always, as you said, Dr. Khan, how do you enforce it? And if it just so happened that China is a country that we have a very difficult relationship with as the United States, and there's tensions, and it was never going to be easy. But I think we have to, on the US side, at least as a foreign policy kind of thinker, I'm curious, like how far this like narrative of being against China or like this competition is going to take us, because we clearly need each other. So I think there's room to have a new conversation, but I'm not sure that politically we're there yet.
So I believe in health of the diplomacy, and I believe if you can't agree on anything in the whole world, the one thing that countries will agree on is saving citizens and saving lives. And I believe that health is diplomacy, and again, this is rose-colored Ali Khan, that health diplomacy is a way to find common ground with countries, and then you can move to all the other, obviously there's numerous issues with China, but I think health diplomacy is a good place to start, to say, this is as important to you as it is important to us for the future of our global economy, because, if the rest of the world doesn't work, that's not good for China. Right. That's the honest truth, right? Let's just be very honest about it, right? So they want to make sure that we don't have the next pandemic, right? And so how do we use good global public health diplomacy to get these agreements in place?
Yeah, I remember when I first started out at the State Department, I was working on the economic portfolio in Southeast Asia, and the bird flu was rampant at that time. And we were fortunate to have a lot of good science diplomacy programs already underway in the region. And so we had resources already placed there. And it was the first time that I learned about science diplomacy. I didn't even realize it was a thing, right? And I think what you're talking about is related, but it's also something unto itself, right? Having that relationship between the public and our global health experts, both in the United States and with other countries, is really important, and not just at the technical level. People need to have, just much more human understanding and of what the vulnerability is and of the cost. So I hope that there's space for it. I hope our friends at the State Department and elsewhere are definitely thinking about these things. So I want to close with just another vignette from one of the chapters, which I found to be very powerful. And then we'll just turn to you, Dr. Khan, for some closing remarks. So at the beginning of chapter 4, it's about smallpox. And so you start it with saying, "We humans act like we own the planet, when really it's the microbes and the insects that run things. One way they remind us who's in charge is by transmitting disease, often with the help of small animals, including rodents or bats. 70 to 80% of emerging infectious diseases are, in fact, zoonotic. The rest, such as drug-resistant microbes, are completely of our own making. And this also reminds me of another theme in the book, which is talking about viruses being intelligent, right? They're kind of these intelligent entities. So really, is this like a struggle between humans and microbes, but it's not really a struggle because they're always going to win? And is this really, again, like an extension of this hubris, this topic of hubris, that we have to like reconcile or accept that this is, this is how the world is, and we have to manage it rather than kind of be superior to it.
So let's not forget the good microbes that give us, bread from yeast, bread, cheese, and if you imbibe wine, right? So there's good microbes out there too. So let's not forget the good microbes also. Don't let all of them give them a bad name. But I think it's important, and this chapter, the point here is, yes, and this goes to one of the questions from Dr. Frost, we will always get viruses and bacteria and fungi that emerge. It's just the nature of evolution, the nature of our increased susceptibility, the changes in societal structure. But epidemics and pandemics are of a human making. Right. And this pandemic is a good example. That part, so the initial emergence is the microbe and the interactions with people and the environment. But the moment we start talking about epidemics and pandemics, those are of human making. And so that's where I would end with, which is that what are we doing in terms of promoting science literacy? Right, which was a big issue during these current times, and political engagement, so that we help our political leadership understand why these are important and why we expect a strong, robust public health system, and why we expect us to be engaging in the world to make sure that they're all protected, because at the end of the day, we're protected.
Yes, well said, well said. Well, I want to thank our participants for their great questions. And Dr. Khan, this is a wonderful book, and I'm going to share it with everyone. I think it's required reading for all of us, having gone through everything the past year. So, and thank you so much for your service and your leadership.
Thank you very much for your time, and thank you for the opportunity to be part of the organization.
Wonderful. And everyone, we will share this online in the coming days, so you can share it with others as well. All right, take care.
Bye-bye.
Have a good night. Bye.
Bye-bye.